И так, все прекрасно. Всем доброго дня. Я рада. Извините, пожалуйста. Так, всем доброго дня. Мы ждем остальных, пока присоединятся. У нас немножко сегодня возникли неполадки, и ссылка у нас изменилась, но я думаю, что нам это не помешает. Итак, сегодня нам прочитает лекцию Люк Хантер. Это практикующий врач из Техаса. Я думаю, что вы все уже про него прочитали, где он учился, чем он занимался, все остальное, самое важное, необходимое, он расскажет сам. И в конце лекции вы сможете задать ему вопросы. Я вас очень прошу, пожалуйста, в течение лекции вопросы не писать, не задавать, чтобы не отвлекать. В конце лекции у него будет там слайд, где он предложит задать вам свои вопросы. И, пожалуйста, ребят, давайте мы будем, как всегда, вежливы, представляйтесь и дальше свой вопрос. Желательно на английском языке. На русском тоже допустимо, если что, мы тут ему переведем. Да, напишите, пожалуйста, сейчас кто-нибудь, слышно нас или нет, хорошо ли у нас все с трансляцией, как видео, как звук. Кто-нибудь откроет чат? Спасибо. Спасибо, Лиза. Еще Лиза. Всем спасибо. Молодцы. Я рада всех вас приветствовать. Все, пожалуй, мы начнем. И так мы немножечко уже капельку задержались. Пожалуйста, Люк.
All right. Thank you for the introduction. This is actually the first lecture I've given remotely. So bear with me, please, and we'll try to figure this out. Let me see. I can start this. Yeah, I'm trying to start it presenter mode. Oh well, just run it in this mode. So the topic I'm going to be talking about today is mainly focused on ATLS, which is the Advanced Trauma Life Support. And one critical component of that is the FAST exam, which is a really forced term, but basically means focused assessment with sonography and trauma. It lets you find blood in different places in a patient. That's very important when you're managing them acutely in trauma, and there might be something dangerously, going on with them that you need to figure out quickly. And so a little background on this. It was created by the American College of Surgeons, which is kind of the general surgeons of the United States as a whole group, and then afterwards they specialize into other things. And so most general surgeons in the U.S. do both elective surgical procedures and trauma surgery, and they take call for trauma surgery, so there's always someone on coverage for each hospital. It's been very successful in the U.S. A lot of its advancements were direct applications of the U.S. involvement in the Korean War and the Vietnam War, and they increased survival in those wars, and then as well from...
They don't see the presentation, so they can't see the slides.
Okay, so apparently you can't see this presentation.
Yes. Okay. You can.
Okay. Oh, sure. We can just start from here. So, let's see. Where were we? And it's just lags.
No, it doesn't matter. It's just this way.
Это я думаю, что еще просто не окстилось, потому что не задержка. Что не пишет? Да, мы можем видеть.
Это не то. Это уже задержка пошла.
Did it create a new link when we did something?
No, it's not.
A third link.
It's something else.
Do you want to switch?
Так, извините.
Не могу помнить, кто-то что-то писать.
We just need to restart the whole thing. See, it's playing some video in the back here. I think the program thinks this window is minimized, and so it's not updating this window, it's updating the back window.
Он говорит то, что вот это вот сзади, видите, идет какое-то видео. Он записывает какое-то видео при этом. Вот это он не видит. Ну, я не знаю, что делать. Он записывает какое-то видео при этом. Вот это он не видит. Ну, я не знаю, что делать. Он записывает какое-то видео при этом. Вот это он не видит. Ну, я не знаю, что делать.
Ребят, как вы поняли, у нас немножко технические трудности. Кто у нас супер владеет YouTube трансляциями? Приходите завтра помочь нам все это организовать качественно и без перебоев.
Он говорит, что если, может быть, потому что вот это он окно в окне. Можно ли это окно убрать, когда он будет, может быть, переключиться на...
Right now it's playing the...
Вот это окно, оно не то показывает.
Я понимаю, прекрасно. Так. Это будет только видео.
Может, закрыть презентацию полностью?
Нет. Очень странно, что не дает.
Can they just restart the program? I think
Можно, может быть, попробуем перейти программу заново запустить, которая...
it thinks that this window is in the background, so it's not rendering new.
У меня такое ощущение, что почему-то все
Changes to that
равно...
window.
А вот там, где справа написано «изменить». Да.
Она все равно слышно, да? Сейчас нужно восстановиться. Нас слышно?
Okay, it looks like it's working.
Yes?
Началось, на всяком.
I think it is.
Нет, да. Окей. Так, тогда...
I think we can just leave
We
it
can
like
just leave
this.
it how it was.
No,
Можем просто оставить
need the video.
Да, правильно. Давайте просто оставим. Без его лица. Потому что у нас была презентация.
Так.
It's just okay. All right, so we'll try to start again. My name is Luke Hunter. I'm an emergency medicine doctor from Northeast Texas, and just finished residency about a year ago. And so just kind of like to share some of the things I've learned, especially in trauma. I worked at a level 1 trauma center for a long time that we saw huge amounts of trauma every single night. And so the way we go about trauma is through ATLS. It's the Advanced Trauma Life Support. And the FAST exam is an ultrasound exam that we use to assess blood and pneumothorax and other things during the process of doing ATLS. And so for the history of the ATLS, it was developed by the American College of Surgeons. It's been adopted by over 60 countries. It's helped a whole lot in the U.S. It incorporated a lot of the experience and knowledge that the United States learned in trauma care in the Korean and Vietnam Wars, and resulted in a lot better survival for soldiers and then, of course, everyone else.
It incorporated a lot.
Sorry, just a second, got some feedback. Okay, I think we fixed it. So there are a few things that ATLS really likes to emphasize. One is that the most important concept is that you identify and treat the greatest threats to life first. So you do not follow a standardized, you don't follow the standard sequential order that you would when you have a patient that doesn't have an emergency, where you would go about asking them a full history, getting all their past surgeries and past medical history, allergies, medicines, then do an exam, then think for a while and generate your differential diagnosis, then order some diagnostics, and then finally decide to do some interventions. Because if you have an unstable trauma patient, by the time you've done all of that, they might have died. And so we try to avoid that. And so we try to organize the way we think about things and the way we do things to do the most important things and discover them and treat them as fast as possible. The second critical concept is that anytime you perform a major intervention, you actually restart the whole ATLS algorithm. Now, that may sound really daunting when you don't understand the algorithm or when you're first learning it, but as you get more experience with it, you can go through it extremely quickly, and it can really save you. I'm not going to have time to emphasize this today, but if you ever take an ATLS course, they'll emphasize this when you do practice cases. And so, you know, there are lots of different ways of handling trauma, and so there are pros and cons to each of them, and each country runs its, you know, healthcare system and trauma system differently. And there are aspects that can always be improved from one to the other, and ATLS is renewed every few years to take stuff from other algorithms and new research from all over the world, and so they're always trying to improve it. And so I think that, you know, myself as a first-year resident, it really helped me because you can be shocked when you see this crazy trauma right in front of you and you have no idea what to do. Like when you get really anxious and nervous, you get what's called perceptual narrowing, and you can't think very broadly. And so you just do immediately what focuses your attention, like a giant broken leg or a bunch of blood on a bleeding scalp. And so that's how ATLS can help inexperienced physicians, is kind of, you know, keeping them on the right track, doing the right things. For experienced physicians, when you do like retrospective studies on how patients get harmed and what happened, it turns out that with experienced physicians, they often have shortcuts and rules that they've learned that are right 99% of the time, but then that 1% of the time they can miss something bad, like a tension pneumothorax, and can result in the death of a trauma patient. And so if you standardize the way you do this, you not only get really quick at it so you don't waste time, but it prevents you from prematurely closing on a wrong diagnosis, and so you don't miss these dangerous diagnoses. And another benefit of ATLS is standardization of care. So when you're talking to someone, you can just say a few things to them, and if you don't say other things, or depending on how the way you say things, they immediately know a huge amount of information. And the standardization also helps get very good research across multiple institutions to improve our trauma care going forwards in the future. And again, the repetition is like any kind of training. If you play sports or whatever, if you do something a lot, then you can just do it with your unconscious brain, and that leaves your conscious brain free to think about the more complicated, fine details of what's going on, and that helps you not make poor decisions. And so I think trauma is particularly important to consider as a cause of morbidity and mortality. And why is that? Because a lot of things that kill people in the developed world, for instance, are associated with old age. And so if you take someone with a hemorrhagic stroke and you do everything perfectly you might only gain them 2 or 3 disability-adjusted life years, because if they do survive, they're going to have a very reduced quality of life, and when you wait a disability-adjusted life year, that you lose a lot of morbidity on that. And so we have about 6 million deaths per year worldwide from trauma, and it's about 20% of the world's total morbidity burden. And so it really greatly affects life expectancy numbers for countries because it kills very young people. In fact, it's the #1 cause of death worldwide until age 44. And so people have noticed that there's kind of a trimodal distribution of trauma deaths, which means there's kind of 3 bumps in this distribution of where the deaths occur. The first peak, all the way over here, happens within seconds or within a minute or so, and these are just huge blunt injuries where the anatomy is completely distorted, or transection of the aorta or spinal cord. And the only way we can prevent those kind of deaths is by having legislation that mandates certain laws like seatbelts, airbags, helmets, and by designing better cars. And in fact, those things have gotten much better over the past few decades, and it's made a huge difference. The peak that we're trying to talk about and affect today is this second peak here. These are acute injuries that a typical person can survive for a short period of time, but if they're not immediately recognized and corrected, can result in death. And so we have a list of things that we consider, that it's not just limited to these, and we don't want to miss any of those, because that would, if we missed it, it could be a person that we could have saved that would otherwise die from trauma. And so the third peak is out here, which is, maybe when they didn't die from the acute event, but they've been decompensated, and maybe they're baseline unhealthy, or they've got an opportunistic infection, and we're unable to manage that. But that's a separate talk, mostly for ICU care. And so it's really nice to organize how the flow of ATLS works, because like I said, it's an algorithm that you want to be able to implement in very crazy situations when stuff's happening really fast. And so it's organized in that if you're lucky and they know the ambulance driving around here, like shown in this picture, gives you a call, your hospital, and says, hey, we're coming in, well, this is what we have, you kind of have time to prepare yourself, and I'll go into more details about that, like how you prepare your room and your staff and everything. And then you do the primary survey once the patient arrives, and that's guided by the mnemonic A, B, C, D, E, which is airway, breathing, circulation, disability, and exposure. And we'll go through each of those in a little while. And then while your staff is getting the patient exposed, you've got a few seconds to get a report from the EMS, which is the guys that brought the patient in and drive the ambulance. And then after you complete that, the patient's fully exposed, you can do what's called the secondary survey, which is where you meticulously go head to toe and make sure you don't miss any physical findings on the patient. After that, you've got time for fast and plain film x-rays. I just made both of them F because it continues the mnemonic with A, B, C, D, and then E being EMS and F being fast and films. And then after that, you do other diagnostics as indicated, based such as CTs, labs, and additional films. Ultimately, when you get all that information back, you're able to reassess the patient and then decide is it safe for them to be discharged, admitted, or they need to go to the OR emergently. And so some of the things you would do if you have notification that you've got a really bad trauma coming in, and I guess I should mention that in a lot of modern systems, they have extensive algorithms based on the mechanism of injury, the person's age and vital signs on the scene and things like that, to where the person is classified as a code 1, 2, or 3 trauma, where code 1 trauma is the most severe. And so that results in some kind of resources being mobilized immediately. So all these people are getting ready for the patient to arrive in parallel. And so you want to mobilize staff. You want to get several nurses to help you. If it's a known head injury or low GCS on the scene, you'll have neurosurgery present on arrival. Trauma surgery will come as well for high acuity trauma codes. And it's very important while you're sitting there, if you're the leader of the trauma team, which is usually the ER doctor, if the surgeon has not arrived yet, or the surgeon if everything, if they're able to arrive in time for everything to start, they will assign which nurse is going to get an IV, which nurse is going to get vitals, because you want both of those to occur at the same time. If you have a resident, you can assign them to do fast or put orders in the computer. You can have your technician put O2 on the patient. So you have like 4 or 5 people doing things all simultaneously. And you're going to mobilize resources to your room, like your mobile x-ray machine, your portable ultrasound machine. And it sounds trivial, but things like C-collars, intraosseous kits, fluids, and blood, because medicine is all about logistics. If you know the right thing, but you don't have it at the right place at the right time, it doesn't matter. And so logistics are very important in medicine. And so if you have a specifically designed trauma room, which most emergency departments in the U.S. do, they're extra spacious to fit all of these people and machines. They have backup oxygen ports, suction ports, and if you're really sticking to what you should be doing, they actually heat these rooms to 80 degrees Fahrenheit, which is pretty toasty, especially if you have all this PPE on. But many studies have shown that that really helps patients in any kind of shock, including hemorrhagic shock. And so I've already talked about some of the resources that you want to have in the room. Excuse me, I'm just going to take a drink of water. And so if you're the ER doctor like me, maybe you're directing all these people to do that stuff, and then while they're all doing their tasks, I double check all the airway equipment, because I'm the airway guy, basically. And so I will check the direct laryngoscope, maybe a video laryngoscope. If I have my endotracheal tube ready with a stylet in case I need to intubate them immediately. We have RSI kits, which is a rapid sequence intubation kit, which already has all the pre-measured doses for different masses of patients, of all the kind of things that you would want to use to intubate someone, so there's no delay between the decision of deciding to intubate and intubate. You want to have 2 suction, because trauma patients have blood clots, emesis, and those things can really gunk up the suction. And BVM is very important as well, because you always want to try to pre-oxygenate people as much as possible before you intubate them. And you always want to have airway adjuncts like a nasopharyngeal airway. That's what NPA here stands for. OPA is oropharyngeal airway, and a bougie, which is just kind of a rigid tube that you can use for several things. And so the setup of the room would be like this, where the emergency medicine physician is typically the airway, and so they're up at the head of the bed. Since they're at the head of the bed, they can also do C-spine immobilization. The trauma physician is here when the whole thing starts, they'll run it. But if it's already started and they come in the middle, the ER doctor will typically run it, because it's very disruptive to switch the leader in the middle. But it makes sense to have the trauma surgeon be the person running it if possible, because they're the one that potentially is going to take the patient to the OR. And you have a nurse on either side of the patient. You assign one to get vital signs. You assign one to start an IV if they don't have one. You have this technician that you have here immediately start cutting the clothes off to do exposure. The respiratory therapist over here has the ventilator, and they're prepping your tube and your intubation equipment if you haven't already done that. Over on this side is the ultrasound. If you have a resident, they'll be here and do the ultrasound once that step comes along. Over here is where you keep your vital signs stuff, and this is the advanced airway equipment that the ER doctor might use. And so, as you can see, you're utilizing every single possible point of contact with the patient to do everything as fast and efficiently as possible, and everyone's role is well defined. And so this is one of the trauma rooms where I train. It's actually a setup that's a mirror image of what I just showed, but you can see that there's an airway equipment here, the video laryngoscope here. We have lights, all of our meds and fluids and things here. We have our blood pressure and monitoring over here. We have airway and code meds and stuff over here. We have all sorts of kits along this wall for chest tubes and things like that. And everyone, this place sees so much trauma that everyone knows all these roles. You don't have to explicitly say them, but in a place like the place I'm working now, where we see much less trauma, this experience has really helped me a lot, because I can be a leader and tell the nurses and other staff, what to do, and that builds everyone's confidence in their team and helps the patient have a better outcome. And so the first thing that we consider when the patient arrives in the room is the airway. And so the easiest way to do this is to say, "What's your name?" And sometimes they say their name, and sometimes they say things that aren't very nice, because they're intoxicated trauma patients, and they get into interesting situations. And so this guy here in this picture is Hank Hill. He's from Texas like me, but he's a little bit different than me. He doesn't know what to think of people sometimes, and they're a little bit different than him. And so he thinks people are a little bit weird sometimes. And so if you think the guy you're seeing is really weird, not talking to you, altered, that could be an indication to intubate the person because they're not able to protect their airway. So if they're not responding to anything you say, you should start thinking, should I intubate this person? And so, you can try to stimulate them with pain or sternal rub or fingernail pressure. And then ultimately you'll decide based on the indications of whether they're too altered to protect their airway, like if their GCS is less than or equal to 8, or if they have an impending airway compromise, like this is a bunch of facial trauma, and so you want to protect the airway from all that continuous bleeding because no matter how much you suction this, it's going to keep bleeding. And then here's like impending airway compromise is a good example. Here is an expanding arterial bleeding neck hematoma. And so that would be, if you saw that developing, you would intubate even if the patient looks fine now because of your anticipated direction this is going to head. Same thing with inhalation and burns to the throat and the mouth. They get very edematous and very swollen, and you want to stay ahead of that and intubate the patient if you're going to consider that to be a problem down the road. And, people that have strokes, especially hemorrhagic strokes, that are causing a lot of mass effect, you'll see a blown pupil, and they're going to have respiratory compromise. And so if you think that they're having a massive bleeding in their brain, you frequently want to intubate them to protect their airway, and also it lets you hyperventilate them to decrease their intracranial pressure. And finally, this is also one of the ways that you can stimulate a patient if you're concerned about their airway, is you can do a jaw thrust, because the typical head tilt chin lift moves the C-spine too much. And in a trauma patient, we don't know the status of the C-spine, especially if it's a patient that's not talking to you. They're not able to communicate, and they're not protecting their C-spine. And so when you apply pressure with your fingers at the jaw like this, it's actually quite uncomfortable. And if they jump up and start talking to you, that's a good sign because you've shown their airway is good. And if not, then it's good because you've opened up their airway and you can see if their oxygen saturation improves, for example. And like I said before, a lot of this is physician gestalt. Like if you think that this person is getting worse, then and you've seen this before, intubation is definitely something to consider. And finally, in trauma, there is also the indication for intubation when the patient is just absolutely crazy and combative. And so I've seen patients that have horrendous wounds, and either they're high on something, or they're not thinking correctly because they've been hit in the head, and you can't do anything. They keep fighting everyone. They are trying to attack people, and you just have to intubate those people so that you can actually care for them. And then one useful technique to know is how to remove a helmet with keeping C-spine precautions. This is an American football helmet, so it's relatively easy. It just goes straight off the top. But just be mindful of this, because some motorcycle helmets, you actually have to rock them forward off the person's face. So just have one person hold the C-spine and then have someone else try to take the helmet off however you best see fit. But just keep that in the back of your head. And so when you're intubating trauma patients, there are some special things to consider. Like I said before, suction is a big deal because they're often aspirating emesis, and they have blood in their airway, and so you want to have 2 suctions because of that. And you want to remove foreign bodies before you intubate, so you want to check for loose teeth, dentures, which are false teeth. And then it's generally become accepted that the standard of care now is to do video laryngoscopy, especially in trauma, because you don't know the status of the C-spine, and with video laryngoscopy, it has a natural large curve to it, and so you don't have to really displace the C-spine very much to get a good view and intubate with that. And as your last resort, you may always have to do a cricothyroidotomy. And this is for that patient we saw. If you were unable to get the intubation that doctor did, you would have to consider going through this route to intubate the patient. And no matter what way you end up intubating the patient, you should always confirm the endotracheal tube placement with capnography, which is like a waveform measuring the CO2 concentration of the exhaled air. A lot of the intubation BVMs have a color change that occurs when they encounter a lot of carbon dioxide. You'll see condensation in the tube, auscultation, and then chest x-ray. And so when you do auscultation, by the way, you listen both over the stomach, and then you have someone deliver a breath, and you check that there's no gurgling in the stomach. And then you also check both lungs to hear that you do have good inflation of both lungs. And this is the example of some dentures that were left in a patient, did a traumatic intubation. Probably it was above the level of the chest x-ray that they performed afterwards, or someone missed this, and so this patient actually, had this sitting in for like a week and got really septic and sick from it. So always check for that right as you're about to intubate. And this is the video laryngoscope that I talked about before, and you can see it has a large curvature to it that lets you intubate without manipulating the head position very much, which is really good in trauma. And so after you intubate the patient, you want to see where your tube went. It's not uncommon for the tube to go in the right mainstem bronchus, like this image here. So you want to identify the carina where this trachea bifurcates, and you want to be 2 or 3 centimeters above that ideally. Healthy patient can generally ventilate fine off one lung, but especially if they're acutely hypovolemic or have other stuff going on, you don't want to let that stay there for very long. You want to back the tube up and intubate them above the carina. So you just measure on the chest x-ray and then retract that much and resecure the tube. Now, that's everything for the airway, and so now we're going to move on to breathing. And when I first learned about this as a medical student, I'm like, well, what's the difference between airway and breathing? Well, airway is like the tube that moves air in and out to get it to your lungs, transport it to your lungs. Breathing is kind of the air exchange and air flowing through the lungs and the whole mechanical function of the lungs themselves in the chest. And so there are very critical findings that you need to search for really quickly. So you listen to both lungs. If you hear asymmetric breath sounds, you could consider a pneumothorax or hemothorax. And in the right clinical setting, like if they've got a huge amount of bruising there, if they're tender there, if they're hypotensive and tachycardic, then you don't know if that's a tension pneumothorax or if it's a large hemothorax or what exactly it is. But the statistics show that if you have absent breath sounds on one side and this constellation of hypotension, tachycardia, and trauma and some injury there, it is best just to go ahead and put a chest tube in, and the patients have better outcomes than if you just kind of let it ride as it is. A classic thing people talk about is deviated tracheas. I recently actually did my ATLS course renewal. You have to renew every few years to make sure that you stay up to date on the newest requirements and all that. And of all the surgeons and ER doctors that were present at my renewal course, they asked us if any of us had ever actually seen a deviated trachea on a patient's physical exam, and no one said yes. And so I think this is a vestigial thing, from older medical education where they didn't have a lot of the modern technology that we have to assess for things. So don't think that the patient doesn't have a tension pneumothorax because you don't see a deviated trachea. It's not reliable. And so if they do have a tension pneumothorax, you do see a deviated trachea, but more commonly you would see, JVD, hypotension, not as poor breath sounds on one side, perhaps. You could do a needle decompression, and that's something to acutely resolve the problem. And that creates an open pneumothorax, and so you have to follow that up with a chest tube, and it's kind of like a temporizing measure. Some people advocate for a finger thoracostomy, and I think that this is actually better because, unfortunately, in the U.S., as people have gotten thicker and wider, a lot of these needles no longer reach the pleural space, and so about half of them on autopsy don't make it into the pleural cavity, and so I think finger thoracostomy is just more reliable. because you can feel when you get into the space. Another thing that you want to look for is paradoxical chest wall motion. This is flail chest. Pretty easy to see, really, once you know what it looks like. It's when you have multiple rib fractures all next to each other and a section of the lung becomes unstable. It actually, the lung underneath that will function pretty well if you intubate the person. It's one of the few things that positive pressure ventilation actually helps with instead of harms. So if they have a giant flail chest and they're having a lot of trouble breathing, just keep that in your mind as well. Sucking chest wound or bubbling chest wound is an open pneumothorax. You can temporize that with a 3-sided occlusive dressing that lets air go out but not in, and then you follow that up with a chest tube. If you hear inspiratory stridor on their exam, consider that they may have some aspiration, like teeth or something they had in their mouth at the time, or these dentures we were talking about. And then part of the breathing is to palpate the chest and the neck area for crepitus. If you feel that, that's subcutaneous emphysema. It's really concerning for there's some pneumothorax somewhere. It doesn't mean it's a bad pneumothorax. It can happen even with small ones, but it means there's probably a pneumothorax. So if you don't see one, it's probably there. Could also be esophageal perforation or rupture, but that's much less likely in the trauma setting. If you do hear crackles and otherwise young, healthy-looking person that doesn't have signs or symptoms of CHF, consider that they've aspirated as well. And so in this image, you can see that the traditionally accepted place to do a needle decompression for a tension pneumothorax is the second intercostal space, the midclavicular line, right here. To find the second intercostal space, you can run your finger down the middle of someone's sternum. When you feel this step off here and a divot there, if you go to the side, that's the second rib. So if you go down past that rib, that's the second intercostal space. You can pretty much feel that in anyone. So you can find that space. But like I said, a lot of times, actually about half the time, needle can't get in there. It's not long enough. And so what a lot of people now are doing are just a finger thoracostomy over here, where you would do a chest tube, which is literally where you just dissect through the tissue and put your finger into the pleural space. And then once you've got that done, a giant rush of air will come out, and then you just put a chest tube in. So that's another option. Here you can see an open pneumothorax. So it looks pretty gruesome. It's the bubbling and sucking chest wound. And so you treat that with the 3-sided dressing. And again, it's a temporizing measure and needs to be followed up by a chest tube. But as you can see, you tape it this way so that when they have inspiration, the dressing kind of occludes the hole, and then when they expire, it lets air out. And this is flail chest. I've seen this a few times. You can see that he has paradoxical respiratory motion, where he's inspiring and the right side of his chest is enlarging like it should, and the left side is actually sinking in. And this is just to help you understand what it looks like on the inside. And now, this is the part where the physician's experience comes into play a lot, where it's your gestalt, your gauging of how is this patient's respiratory status. Are they retracting? Are they using accessory muscles? Do they have nasal flaring? Are they speaking in like single words because they're gasping for breath so much? Those are all subjective things. There are also objective markers like the respiratory rate, which, you know, humans counting those aren't very accurate because we aren't patient enough, but machines are pretty good at counting those now if they have a good waveform. The SpO2 is objective, but keep in mind, again, it needs a good waveform. If the waveform is not smooth and repetitive, it's inaccurate because wherever you have it on their forehead, their ear, their finger, their toe, or wherever, in a setting of trauma, it can be vasoconstricted and falsely report a low SpO2. If you have concern that that's true, you would get an ABG. That'll tell you the exact SpO2. If not, I try to stay away from an ABG and use a VBG. It tells me the acid-base status, same information, but it's much less painful for the patient. And a lot of times, you know, you don't have to get a second access point. If you already have venous access, you can just draw it off that. And then you can put a patient on end-tidal CO2 to see how, how much they're ventilating. And now kind of the next part of the algorithm. So we've done A, B, and now we're at C, which is circulation. And so that means kind of like the body's ability to move blood around and actually having blood inside of your body. And so, as you know, most people from trauma die from hemorrhagic shock. But you don't want to prematurely narrow your diagnosis on hemorrhagic shock. And so look for just signs of shock in general, like altered mental status, poor cap refill, tachycardia, hypotension, diaphoresis. Those can all be in a syndrome that's of shock. And so if you can't get a blood pressure machine to get the blood pressure, or if there's too much noise or you can't hear it, this is a handy rule to know that if you can palpate a radial pulse, their systolic blood pressure is above 80, femoral pulse is palpable, their blood pressure is above 70 systolic and 60 for carotid pulse. So this can kind of give you an idea if you're getting stuck on this point. And so if you really don't suspect a shock state in this patient, you can cease this step and actually go on to the next step, which is D for disability, which is neurological type exam. But if shock exists, and it frequently does because this is what kills the most people in trauma, you want to assume it's hemorrhagic shock until proven otherwise. And so I know I just said don't prematurely close, but you're keeping in your head that you're functioning as if it's hemorrhagic shock, but you're investigating other causes. And so the first step you need to do is control source of bleeding if you can identify it. And the second step is to replace volume, such as blood with blood or fluids. And so you want to address life-threatening external bleeding. And so people frequently bleed from the scalp. And you can put a pressure dressing on this. If that's not sufficient, you can do figure 8 suture. And you can just do a quick Google image search on how to do that. It's pretty easy, pretty fast. And you can just throw those blindly into tissue that's bleeding really badly, because the idea is to just throw them down really quickly and stop dangerous, life-threatening bleeding, and then later you'll go back and revise it and make it look nice and everything. If you're bleeding from an extremity, like an arm or a leg, you can tourniquet that. Pretty straightforward. Junctional bleeding is a little bit more difficult to handle, and so that's bleeding at like where your extremity attaches to your body. So like armpit, groin, it's kind of difficult to put a tourniquet on those places. It's impossible, really. And so you can apply direct pressure. They have some fancy devices that are okay at occluding the arteries to these places, but they're not super good. One thing that's becoming more common is Reboa, which is an arterially introduced balloon that you can actually navigate to the site proximal to the arterial bleed and temporarily inflate to occlude the bleeding while you stabilize the patient, take him to the OR, take care of their other injuries, for instance. Because a lot of times limbs can take ischemia for a good while. I mean, not forever, but definitely longer than your brain and your heart can. And then, last case for any kind of hemorrhagic shock is always a resuscitative thoracotomy, where you cross-clamp the aorta and do a bunch of other stuff. But, I'm not really going to talk about that during this lecture. It's like a whole thing by itself. If they're bleeding on their trunk, kind of the best thing you can do here is to just very aggressively pack and hold pressure. And so, especially if you can get out clots so that you just have the pure cavity, and then you rapidly shove in a bunch of procoagulant gauze and then put a pressure dressing on top of that, that actually frequently works very well. And for other things that can cause bleeding, it's a little bit more tricky when it's internal bleeding, because we can't see inside the patient, well, at least not as easily. And so there are a few places that you can have life-threatening internal bleeding. So you can have internal bleeding in many, many different places, but life-threatening internal bleeding is only a short list of places. So the thoracic cavity, which you can check with a chest X-ray. If you have high clinical suspicion, you can do a lateral decubitus film that's a little bit more sensitive than a supine film. And then in between those two would be an upright film, as far as being able to catch a pleural effusion or blood or whatever. And then, again, if it's something that's affecting their hemodynamics, making them unstable, you want to proceed to chest tube. Otherwise, sometimes it can just be monitored. For bleeding in the peritoneal cavity, you do the FAST exam, which we'll talk more about detail later. But you basically check several quadrants in their belly, and then if you see free fluid there in the setting of trauma, you presume it's, traumatic bleeding in that space. And so you basically take the patient to the OR, because how are you going to address that bleeding otherwise? This is where you stop what you're doing and you send the patient to the OR and you don't even complete the rest of the exam. Retroperitoneal bleeding is difficult because we don't have a extremely direct way to find that. And the periumbilical ecchymosis and flank ecchymosis that they teach you in textbooks is actually pretty rarely present when people have retroperitoneal bleeding. Another mistake I see people make with this is they see any pelvic fracture and they're like, okay, pelvic binder, apply it, problem solved. But no, you only put a pelvic binder on someone that has an open book pelvic fracture, because it basically reduces the potential space that they can bleed into. If you put a pelvic binder on a patient that has a completely shattered and pulverized pelvis that doesn't have any anatomical resemblance to a pelvis anymore, when you put that pelvic binder on them and tighten it up, you're just going to rip apart all of the venous plexus in their pelvis, and they're going to bleed to death really fast. And so keep that in mind. Eventually, the definitive care for this will be to go to IR often to get embolization of the sources of bleeding, or just observation, or sometimes go to OR with orthopedic service. But for the acute stabilization, the pelvic binder is what you would use. Now, a femur fracture, especially a midshaft femur fracture, is a place that you can bleed a significant amount of blood in that can be life-threatening. And so generally this is a clinical diagnosis. If you see a giant amount of ecchymosis there and a gross deformity, you can kind of be safe assuming that, but you can also get the film as well. There's not a lot you can do, though, to stop the bleeding in that site. If you put too much pressure on it, you can cause compartment syndrome. So you kind of approach this with volume resuscitation, because fortunately this place is not it's the smallest compartment of all these compartments that you can bleed into. And so we've talked about controlling the source of bleeding, and then what about replacing, our intravascular volume to make up for stuff the patient has already lost or is losing now that we can't quite stop. So, on every test question in trauma, if you don't know what to say, you always say 2 large bore peripheral IVs, because they are able to infuse blood and other products very quickly. Ultrasound IV skills are very useful for getting these as well, because a lot of times if these patients are very volume depleted, there's like nothing you can go for on some patients who have poor veins. And then if you feel like this is a pretty emergent situation and no one can get access on the patient within 1 minute, you can always just place an intraosseous access either in the shoulder or below the knee. These are actually great. You can basically put any medicine in them. They're very well tolerated. They're very easy to put in. I think they're very heavily underutilized. You can also use a Cordis catheter, which is a central line, but it has a single lumen that is very short and very wide, and so you can actually get fairly high flow rates with that. And so once you've got access, you can decide, well, what am I going to use this access for? Like, am I going to give them blood products, crystalloid, or what? And so the exact numbers change year by year, but in general, we don't want to give too many crystalloids to trauma patients because it further dilutes their blood and makes them more coagulopathic. And a lot of times things like normal saline worsen acidosis, and then that changes all of your biochemistry and can denature and make your coagulation proteins function less efficiently. And so at most 1 to 2 liters of crystalloid. The current recommendation for ATLS is 1.5 liters at most. And so after you've done this, you can kind of reassess, and then if you think you need to take the next step, you can go to using actual blood for resuscitation. And so I wrote here 1 to 1 to 1. So that's like 1 RBC unit to 1 FFP to 1 unit of platelets. And the idea is that you're covering all the different, possible things that can cause coagulopathy. And also the FFP is like a volume resuscitation in itself, and it has an oncotic pressure. And so you can actually start giving these with no labs. It's indicated actually if the patient, is clearly has hemorrhagic shock and is not doing well. And I wrote here that you use FFP first because it actually has the lowest viscosity between the platelets and the RBCs, and so you can get that in the fastest. And also, in patients that arrive to the ER and aren't just straight out dead, it's usually a lot of times venous bleeding because arterial bleeding can make them bleed to death quite quickly. And so the FFP helps a lot with venous bleeding. And so one device that I really like for infusing is called a level 1 rapid infuser. It can't do cryo or platelets because it's actually so powerful it shreds and destroys those. But it's absolutely amazing. It can warm and infuse blood and transfuse an entire unit of blood in 5 to 10 minutes. And so like if you get one IV in each arm, you can do 2 units of blood in 5 or 10 minutes into a patient. And it's in patients that are critically ill or have DIC or you can't control the bleeding, you can keep them alive and actually just tamponade their source of bleeding. And I know it sounds sloppy, but if the patient survives, that's what we want. And so if you think the patient does have DIC or coagulopathy, you can check some of these labs I've listed here, but I won't go into too many details for that. For the access of the patient, this is just kind of a table to emphasize what I was saying a second ago, that as you can see, peripheral IVs have really good flow rates compared to other things, like triple lumen is pretty poor, where central line's only 30. And the IOs actually do have really good flow rates. And I believe this chart might be underrepresenting the shoulder humeral IOs. They actually have a little bit higher flow rate than this. And so this is kind of the final trigger, the final thing you can do to help someone that's bleeding to death. Is a lot of institutions have what's called MTP, which stands for Massive Transfusion Protocol. And this is just an example of that, but you can see that it has a pathway of who does what happens, and usually what it is there's like a big bag somewhere, stored somewhere, that has a bunch of uncrossed blood and everything all ready to go. And so when you activate MTP, that instantly becomes your patient's blood and goes with them to the ER, the scanner, to the ICU, to the OR, and so you have just continuous blood for a period of several hours before your lab has to catch up and start delivering blood to you as you need it. And so that saves a lot of logistical problems. And so going back to talking about chest tubes, I mentioned that if you have a hemothorax or pneumothorax and it's causing them hemodynamic instability or respiratory problems, that's usually an indication in the setting of trauma to do a chest tube without any other sort of confirmation. Now, when you put in a chest tube, sometimes you can just get if you get greater than 1,500 cc's of blood out. That is very concerning for like a tracheobronchial tree injury where you're bleeding from one of the pulmonary arteries or veins, or that you're even suctioning blood that's coming out of some traumatic, rupture of the heart or something. And so obviously you don't just want to exsanguinate the patient through your chest tube. So you clamp the chest tube and you send them to the OR. You don't continue any more ATLS at that point. That's intraoperative. And so alternatively, if you have these, continued moderate flow rate for a while, you would also have the patient go to the OR to get that investigated. Now, we've talked about a lot of hemorrhagic shock, but let's think of other kinds of shock that might be going on in a trauma patient. So they could have neurogenic shock from spinal cord injury. They could have drug or intoxication. It's very comorbid with trauma. They could have obstructive shock from tamponade, cardiac tamponade, not usually PE, could have a tension pneumothorax. There are a few others that aren't in this table, but those are the big ones. And so for cardiac tamponade, basically it's you have some injury that causes bleeding between the visceral and parietal pericardium. You get RV collapse, so blood can't enter the right ventricle, and so then the right ventricle can't send blood to the lungs and so on, and you get obstructive shock, and your heart's working, muscle and everything, but it just can't fill with blood because the right side of the heart has lower pressures. It's been overpowered by some bleeding in the pericardium. And so if you have a patient with a penetrating trauma wound to the cardiac box, that's 80% tamponade. So if it's a knife or a pick or something puncturing, the exception to this is a gunshot wound, because it's so blunt and destructive that it actually creates such a large defect that it usually destroys the pericardium enough that you don't get tamponade from that. You can get it from blunt trauma, from like a steering wheel injury to the chest. The Beck's triad is another one of these test questions that is not very clinically useful because it's seen so rarely in patients that have cardiac tamponade. But the triad includes hypotension, muffled heart sounds, and JVD. The same for pulsus paradoxus. It's a good test question because it allows you to explain a lot of pathophysiology, but it's very poorly reproducible between multiple practitioners, and it has poor sensitivity and specificity because for that and other reasons. In general, you should just have a high suspicion based on the patient being short of breath, hypotensive, tachycardic, and having JVD, and the right mechanism, or bruising or tenderness over the chest there. And so how do you differentiate this from tension pneumothorax? This is kind of a good test question that's always brought up. And so, especially this is where the tracheal deviation might come into play, where with the tension pneumothorax you might have tracheal deviation. But in the real world, a chest x-ray and a fast exam will help you determine if it's tension pneumothorax or cardiac tamponade. And so the fast exam will see the free fluid around the heart. The chest x-ray will see the tension pneumothorax, and you can also put a linear probe on the patient's chest with the ultrasound and see a pneumothorax. So sometimes, no one thinks about this, and you get an EKG like this, and you're like, wow, this guy actually might have cardiac tamponade. And so what you see is it's usually sinus tachycardia, low QRS amplitude, and electrical alternans. And so what that means is like every other beat is alternating between high and low amplitude. Now, a low QRS amplitude can also be seen in really obese patients, and something that mimics electrical alternans can be seen when a patient is hypovolemic. So if their heart rate is very fast and their respiratory rate is not as quick, you can see an envelope waveform similar to this, but it's usually not every other beat. It's like over the course of 3 or 4 beats, the QRS will get bigger, and then over the course of 3 or 4 beats, it'll get smaller, and so on. If it's exactly every other beat like this, that's electrical alternans. Now, if you get a chest X-ray and you see this is also concerning for cardiac tamponade. It's the water bottle finding on the chest X-ray. And so, but of course, the best way to diagnose it is with just throwing an ultrasound on it right at bedside. And so, again, you see that the right ventricle is the most anterior part of the heart. It's right here near the chest. You see the effusion on both sides. And this is just, from a physiological standpoint, what's occurring when you see electrical alternans, the heart waggling around inside like this. Now, fluid around the heart doesn't mean they have cardiac tamponade, because cardiac tamponade means that there's some obstructive physiology occurring where the blood buildup is actually crushing the right ventricle. I won't go into the full details of how you do this, but basically doing M-mode ultrasound is a way you can quickly find this out in a few seconds. And it's a little bit difficult to explain, but once you got the concept, it's pretty you'll always remember it. And so, to wrap up on cardiac tamponade, I'll talk about the treatment. So again, I say you only treat if there's collapse and diastole, because that means there's tamponade physiology. You do everything you can to not harm the patient, so you don't, give them nitroglycerin or diuretics because they're preload dependent. Instead, you should be giving them IV fluids or blood, of course. And then, if you're getting your stuff together or the right person's not available, you want to give the heart more inotropic support. You can do that through dobutamine. But again, it's only temporizing. It's not going to solve their problem. If it's traumatic tamponade, pericardiocentesis is done, and then you need to do a thoracotomy to be sure there aren't any other injuries there. If it's non-traumatic, I just included this for completeness sake. You can do the pericardiocentesis and then follow it up with a 3-way stock cop, and then people can figure out, what exactly is the etiology later, and you don't have to be as, drastically interventionalist. This is just an ultrasound picture of how you would aspirate the fluid from a cardiac tamponade collection. Traditionally it was based on landmarks and everything, and you could attach a alligator clip to the needle and connect to an EKG and all this stuff, but ultrasound is just so much more direct and safe that it's pretty much become the preferred modern approach. Something people don't think about is blunt cardiac injury. So again, if you get like a steering wheel to the chest, you can actually get cardiogenic shock. And it's a spectrum of disease. It goes all the way from just a contusion where the heart's a little bit weak, to some weird arrhythmias, to a full-out infarction from a dissection or a thrombosis or just direct death of the tissue, to, they can have myocardial rupture. So these are all things to keep in mind. And so this diagnosis is really hard to make acutely, but if you have, blunt cardiac injury or tachycardia, weird arrhythmias on your monitor, and the patient has the right story, get an EKG to be sure they don't have an MI or something. If you're really suspicious, you should also get a cardiac CTA. It can look for this aneurysmal dilation prior to a myocardial rupture, and you can get a cardiac echo, but these are like less acute. Neurogenic shock is something I mentioned a while back too. It's when you get like a blunt injury or stunning to the spinal cord that causes loss of sympathetic function. And so the patient will, the exam question will be if they're hypotensive and bradycardic, which is kind of paradoxical because all the other things in trauma typically cause hypotension and tachycardia, and that causes warm extremities. Because their sympathetics are non-functioning, they're vasodilated everywhere, and that's what's causing their shock. And so that's why they have palpable warm extremities. Now, I highlighted this 85 MAP goal here because pretty much everywhere in medicine you always see MAP goal greater than 65. But for certain kinds of spinal surgeries and neurogenic shock, you want to try to maximize the perfusion of the spinal cord, and they changed the MAP goals to greater than 85. To achieve this, of course, first you need to use volume resuscitation if they have ongoing volume losses or have suffered a volume loss, but then after that, you can use norepinephrine or phenylephrine. And you can adjust the heart rate with atropine, and you're going to give them large amounts of fluids, and you want to be sure you use normal tonicity fluids because you don't want to overwhelm someone's potentially injured kidneys with hypotonic fluids and cause all sorts of bad problems. So to move on to disability, this is the D part of the exam. You'll calculate GCS. I know with our initial technical issues, we are a little bit behind on time, so I'll try to skip over a little bit so we don't run too far over for people that have to go to other places. But basically, you would assess the pupils, assess their verbal response, their motor response, their eyes, and then you generate a score between 3 and 15. And common exam question is less than or equal to 8 is that you intubate. And so, especially in the U.S. and other countries that have opioid overdose, you should have a high clinical suspicion for this if they have pinpoint pupils. It's another thing that can sometimes cause hypotension and bradycardia, and apnea or very, very, very shallow, infrequent breathing. And so you can give doses of naloxone, and you can even give astronomically high doses for some of these synthetic fentanyl and carfentanil and stuff can take absurd amount of naloxone. So just keep that in mind. And now if you are concerned that they have a head bleed based on neurological findings, blown pupil, all that stuff, you know, there's only so much you can do acutely as an ER doctor or when you're with the patient and you're not a neurosurgeon. You elevate the head of the bed, that gives you some benefit with the intracranial pressure. You can consider mannitol and hypertonic saline, intubation for hyperventilation and airway protection if they're herniating, neurosurgery consult. Very important, especially in older patient populations. You want to see if they're on anticoagulants and reverse them. The exact reversal depends on the particular anticoagulant, though. And you're pretty sure they're going to go to the OR somewhere, and so you might want to get some basic screening labs to be sure that you're not missing anything like a heart attack or an unknown underlying heart condition or something. And so now we advance to E, exposure, and environmental control. So this is pretty straightforward. You completely remove all the patient's clothing. I mean, within reason, if they're, talking to you and compliant, they can be covered and take off their clothing. But if they're altered or, confused, don't bother. Just cut their clothes off because you're trying to save their life. They could be very seriously injured. And don't be lazy either. You have to look under bandages and under wound dressings and stuff too. And again, you want to avoid hypothermia because you've just taken all their clothes off, so you want to keep the room warm. You're going to have warm blankets and warm fluids. When you talk to EMS, you're going to ask them, so basically, while your staff is exposing the patient, it's kind of difficult for you to do stuff, and so while that's all ongoing, you get the EMS report. And there's some acronym called AMPLE, where you get the allergies, meds, past history, last meal, the event description, and what they've noticed on the patient so far, like, he's got a big laceration to his left lateral flank. You asked him what happened en route, like trends of vital signs are very important. Blood sugar I would consider as a vital sign as well. You want it on everyone by EMS. You asked them if they got any access, if they gave any meds en route. This is really important because maybe they tried to intubate the patient in field and paralyze them. That's really important to know, so ask those questions. Let's see. And the secondary survey conceptually is pretty easy. You just go from head to toe. You palpate every part of the patient to make sure you don't miss any dangerous injuries. You do each arm, each leg. Once you've done all that, you roll the patient. It takes at least 4 people to do it with full C-spine precautions, as illustrated here. If one person holds the C-spine, 2 people interlock their arms, and then the 4th person is the guy taking the picture here. And so you would grab that backboard, pull it towards yourself to get it out from under the patient. Watch out for glass fragments or things that are from windshields. And then you palpate along their spine, the back of their scalp, behind the C-spine. I presume this guy is their friend, so they didn't cut his clothes off, but his clothes should be off. And common areas that are overlooked are the axilla, groin, gluteal cleft, and rectal tone. Do that if the patient is unable to respond and you don't know if they have some sort of cord injury. And so you also want to check all the distal pulses to be sure they don't have a neurovascular injury. You want to range all of their joints. I aggressively range all of their joints and very aggressively push on all of their bones. I'm trying to get them to show me something because they're often distracted by certain injury and don't even know that they have other injuries. And so at this point, you can go to FAST and films, which is the ultrasound exam and the x-rays. And so again, the chest x-ray can show us pneumothorax, hemothorax. The pelvis film can show us if we have an open book fracture. Femur film can show us if we have midshaft fracture. The FAST has these different views. To save time, I won't go into too much detail on those. But basically, the algorithm is right here. So if you have someone that's hemodynamically stable or unstable, and you get a positive FAST exam, then that means they have fluid somewhere in their belly. They need to go to the OR because we're not going to be able to fix that right now. Otherwise, you don't even assess the D or the E or the other stuff. You just say, okay, they're bleeding dangerously in their belly. Take them to the OR. And then it is sometimes useful if the patient looks very well appearing that you can spare CT scanning them if they have a negative FAST exam or do serial FAST exams to confirm that they don't have any intra-abdominal bleeding. And so at this point, there's not so much of an algorithm, and then you go back to your clinical judgment and your experience, and you decide if you want to get CT scans, what you're going to CT scan. There are some general rules about those, though, individually. So I've listed some of the things here that would prompt you to order a CT head based on a pedestrian being struck by a vehicle, someone ejected out of a vehicle, a fall from a building or a tall ladder, age, because the bridging arteries in your head are more likely to bleed once you reach a certain age. Evidence of skull fracture, like depressed or boggy skull or step off on the skull, very altered. abnormal neurological status, like if they're not moving one part of their body to pain. There's a list of C-spine. There's lots of CT C-spine rules. This is one of them that I like just because it's fairly simple, and the overly complicated ones are not really suitable to implement clinically, in my opinion. And then the chest and the abdomen, pelvis, these are always with contrast. And these two up here, the CT head and C-spine, are always without contrast. Just keep that in mind. So the CT chest you should get if it's like a very high energy mechanism. Same for the abdomen, or if they have a seatbelt sign, which is just giant ecchymosis across the belly. I just included this tiger or this lion here because my hospital that I trained at is across from the Houston Zoo, and in Texas we have Texas-sized people, and so some of the CT scanners aren't Texas-sized CT scanners, and so we actually sent our patients to the zoo to be scanned on a large animal CT scanner. So this is the opposite. Sometimes, we got to pay them back and let them use our CT scanner. And so again, this is kind of a crash course for ATLS. I know it's a lot of information. I'm a really big fan of it. I think that it does save a lot of lives. If you're interested, just Google ATLS and you can search. There are courses all over the world. They're very, very good in person. The people that teach it and certified to teach it are great. You'll do everything in groups. You get to do lots of stuff with mannequins. You learn lots of physical skills. And no matter what kind of physician you are, you always have the chance that you could be exposed to trauma, whether you're walking on the street and see an accident, or if someone comes into your clinic or your hospital and you're the first person there. And so I encourage you to keep all that in mind. And thank you for listening. I'll be very happy to address any questions or comments, and you can send me email at this link here. And this is just some of the my friends that I went to residency with in one of our trauma rooms and our awesome ultrasound, and I'll be happy to show anyone ultrasound, anything, anytime. So I hope you enjoyed the lecture, and let me know if you have any questions. Thank you.
Yes, I want to switch to your face so you can answer.
Yeah, I'll be right back. I'm just going to get some water. And then I'll answer questions.
А вот все, что может ответить на вопрос, вот сейчас.
Да. Так, коллеги, пока у нас небольшой перерыв, мы сделали буквально 3 минуты, поэтому пока вы можете писать вопросы, и наш лектор к вам вернется, обязательно все ответит на все вопросы и уделит каждому внимание. Вот, пока, чтобы не выключать трансляцию, чтобы у нас не было никаких технических палаток, пока оставляем так. Привет. Так, ребят, еще раз здравствуйте. Точнее, продолжаем общение. Пишите, пожалуйста, в чат свои вопросы. Вот сейчас пора. И никто не пишет. А уже надо. Ой, какие вы заботушки. Хорошо, доктор Люк. Thank you so much. Thank you so much. Это вы попозже скажете. Сначала вопросики, мои хорошие. Давайте. Так, ребят, ну давайте вопросы. Ну что такое? Можно писать по-русски, мы переведем. Все, Люк вернулся. Давайте уже. Скажи, что они не могут писать на английском. Сказал, что они писать на английском, но пока они не пишут.
Yeah, they told them that they can write stuff in Russian. how stressful is it for you personally to work in the ER?
I've talked about this before, and people get used to a lot of stuff if you do it all the time. So if you think about it, none of us are made to be in a car right next to another car going 70 miles an hour just a few feet away from us. If you think about that, that's not very natural. It's pretty scary. I think that the ER is the same way. If you do that every day, it becomes normal to you, and you know what's safe and what's not safe and how to be careful. I think that the most stressful part of the job is when there's just not a perfect solution, because you have lots of different consultants on really complicated trauma patients. They all want different things, different priorities. You have the trauma team, you have the ER doctors, the nurses, the patient's family, and so a lot of times there's many different competing views, competing priorities and goals, and you have to juggle all of that. And sometimes as the ER physician, no matter what you do, you're going to make someone really angry at you, and so you kind of just have to decide sometimes, and that can be stressful.
Can you please repeat what blood 1:1:1 means?
1:1:1 is a ratio of blood products, and so the different components are RBCs, platelets, and FFP, which is fresh frozen plasma. And so the FFP has like the venous coagulation proteins. The platelets are good for arterial bleeding, and the blood is, important for perfusing the person. The MTP protocols often have cryoprecipitate, which has fibrinogen and other stuff like that in it. And so you can assess whether you need that by checking the fibrinogen level or getting a thromboelastogram if your facility has one of those. And some places also use tranexamic acid, but it's based on trauma protocols. And I think that overkill for that question. We'll go on to the next question.
Another question is, could you please recommend literature about ATLS?
Honestly, if you want to get a very clinically relevant, clinically focused summary of anything in emergency medicine, I actually am a really strong advocate of the emergency medicine wiki. It's called WikEM. So if you type in WikEM, tension pneumothorax, it will show you all the stuff about tension pneumothorax that you need to know to keep a patient alive, and it cuts out all the stuff that is interesting from a research standpoint, but to help you make your decision right now might not be relevant. And so it has a guide in there for ATLS that is a really good summary of all the different steps I just discussed. And it always has links to primary resources, but I think that's a great place to get started. There is also, the ATLS course itself that you can always search for and enroll in. It's offered in many different countries. Any other questions?
Okay, another one. How often does your hospital provide training for emergency doctors? How often does your hospital provide training for emergency doctors?
So, my hospital now does not provide training for ER doctors. But you do have to be board certified, and you have to do a maintenance of certification, and they require that you have that. And so they kind of offload the training onto you, and then they make you also have your ATLS stay current, which means that every few years you have to get all the updates and do an in-person course and demonstrate your skills on mannequins with intubation and all these other procedures we talked about.
I think they might mean that a hospital is trained in.
Oh, how often? Maybe how does your hospital provide training, I guess?
Well, they ask how often.
So, I think in one way you could say every day, because as a resident in the U.S., things are very hands-on, and especially at my hospital that I trained at, it was in an indigent care inner city community where 45% of the population of Houston are illegal immigrants, and so the only option for healthcare they have is through our facility. And so it's like insanely busy and very low number of physicians per patient, and so they let you do tons of stuff. And if you just need to know what you don't know. That's the most important things. And if you don't know how to do something, you ask them to show you, and they're almost always very happy to show you. Okay, well, I guess that's the end for today, but thank you for listening.
Oh, no, it's nothing. Another one. Should we take it into account by the 2015 recommendations of CPR, we should start resuscitation with CAB?
Yes, and so, a lot of times we have these clinical rules and guidelines and algorithms, and people forget what the inclusion criteria for those algorithms are. So the inclusion criteria for ATLS is that you have a person that is presenting to your hospital in the setting of trauma. Whereas the inclusion criteria to be on the ACLS, not ATLS, but ACLS algorithm is someone in whom you suspect a medical problem who's presenting, with tachycardia, bradycardia, that's either symptomatic from both or, in full-blown cardiac arrest. And so they don't conflict. You still do everything A, B, C, D, and E. And as you say, you do CAB when you were doing ACLS. All right. Well, please feel free to email me. My email is lukhunter@gmail.com. And thank you for listening.
Oh, save it tomorrow.
Yeah, I'm also giving a lecture tomorrow on medical physics and some related topics, because I used to do that stuff before I got into medicine. Okay?
Thank you so much.
Thank you again.
Спасибо, мои хорошие. Отдельное спасибо за вопросы. Прям молодцы, не подвели. Всех целую. Запись. Это мы потом сотрем запись, если она была.